Um, we have a chat feature here in BlueJeans, which you will see in the upper right-hand part of your screen. As Dr. Hunter is going through the presentation today, if you have any questions that you'd like to ask, please feel free to chat those in. I am going to ask you to keep yourselves muted for audio and video so that we have a good connection and we can all follow along with Dr. Hunter's presentation. So please feel free to chat your questions in. Dr. Hunter did allow some time at the end of her presentation for some Q&A. And we did have some questions submitted ahead of time, so hopefully we will get to those as well. So anyway, I again want to welcome you to our dementia discussion today entitled Forget Me Not, Coping with Changing Memory with Considerations for a Global Pandemic. And it was with a great pleasure that I introduce to you our speaker today. She is absolutely delightful, and you will very much enjoy this presentation. Sarah completed her doctorate in nursing practice from the Ohio State University College of Nursing in May of 2019. Her doctoral evidence-based quality improvement project focused on providing concussion education to family practice and pediatric providers. She completed her Master's of Science in Nursing through the University of Toledo, where her thesis focused on helping caregivers of individuals with Alzheimer's disease be connected with support and resources in the community. She graduated with her Bachelor of Science in Nursing from the University of Mount St. Joseph in Cincinnati. And since graduating nursing school, Dr. Hunter has spent her career focused in neurology. First 4 years in the Toledo Hospital Neurology Intensive Care Unit, and the past 5 years in outpatient neurology practice at ProMedica Physicians Adult Neurology with Dr. Loomis at Levis Commons. She treats all adult neurological patients, but her areas of clinical interest include concussions, TBIs, memory adult neurological patients, difficulties with headaches, and multiple sclerosis. And once we eliminate barriers to practice, she would like to integrate a concussion clinic for high school and older patients into her current practice. And Dr. Hunter, as a huge football fan, I am very interested in that research and practice in concussion protocols. So thank you for doing that. Sarah is one of the Toledo chapter leaders for the Association of Advanced Practice Nurses. And on evenings and weekends, you may see her officiating, in the spring and summer that is, you may see her officiating girls lacrosse games or attending a boys lacrosse game that her husband coaches. That's really cool. So in her free time, she and her husband enjoy traveling, gardening from seed, tending to tropical plants, completing house projects, snowboarding, and wakeboarding in the muddy Maumee River. So I give you a lot of credit, Dr. Sarah, for doing that as well. So without further ado, I am going to turn you over for the next few minutes with a real treat to hear from Dr. Sarah Hunter. Sarah, take it away.
Okay, can you all hear me?
Yes.
Okay, good. Fantastic. So thanks for having me. I'm very excited to get the chance to do this. Uh, as you mentioned, my master's project focused on memory care and caring for caregivers. So dementia is one of my favorite areas to treat. There's a lot of room for education available. So we'll go ahead and get started. So it's Forget Me Not. We can go to the next slide. Okay, throughout the course of this presentation, we're going to discuss the 10 early signs of Alzheimer's, evaluation for memory, planning ahead, memory problems during the pandemic, caring for the caregiver, and research opportunities. So from the Alzheimer's Association, here are the 10 warning signs of Alzheimer's. It's memory loss that disrupts normal life, challenges in planning or solving problems, difficulty completing familiar tasks, confusion with time or place, trouble understanding visual images and spatial relationships, new problems with words, in speaking or writing, misplacing things and losing the ability to retrace steps, decreased or poor judgment, withdrawal from work or social activities, or changes in mood and personality. Okay, so for evaluation for memory and seeing a specialist, I practice in neurology, so this is what I do on a regular basis. If you're coming to my office to be evaluated for memory, um, you can probably expect me to be in the room for about an hour. Um, I spend a lot of time with the patient and the family, and when I take a thorough history, I'm mainly addressing the patient. I want to hear from them what their insight is to their problems, and then I'm watching out of the corner of my eye the family members, seeing if they're shaking their head and disagreeing, or if there is disagreement, then I ask for further explanation. So what kind of questions we ask are, when did the problems begin? Was it sudden or gradual? Was there an injury? What kind of changes have been noted? Are you getting lost driving in familiar areas? If you normally do the grocery shopping, are you having problems? Are you making a list? Are you able to get everything off the list? Are you getting extra items? Are you getting unusual quantities of items? Unusual quantities of items may be a judgment issue. Are you cooking? If you're the cook of the household, are people complaining that you're not able to follow a recipe? Does your food that normally tasted great not taste good anymore and the family doesn't want to eat it? Are you paying bills on time? Are you double paying? Are you missing payments? Are you able to do your household chores? Personal grooming issues, toileting, balance or falls, hallucinations, sleep. History is also very important. If you're not getting good quality or quantity of sleep, it can cause like a pseudo dementia. So if you're not getting good quality of sleep, you can have memory problems. Um, what your educational history, work history, medical history, and medications you're taking. Sometimes different combinations of medications might cause some issues. And then the social history. Alcohol use, smoking, and drugs, as they can affect the brain. Okay, next. Okay, so then we move on into a more physical exam. We're doing a full head-to-toe neurologic evaluation, seeing if there are any gross motor deficits that might indicate a structural issue. So if things that might indicate like a tumor or mass in the brain, are there any visual or hearing deficits? If the patient's hearing is severely impaired, maybe that is why they aren't remembering information that was told to them. Or if they're a visual learner, if their vision is severely impaired, they might have difficulty remembering information as well. We're looking for changes in speech, whether it's they have difficulty answering questions, the fluidity of their speech, following commands, naming items, completely wrong words coming out, and if there's any difficulty with repetition. Have any of the primal reflexes returned? Do they have a grasp reflex, a startle response, past pointing? And then we ask some short-term and long-term memory questions as well. Okay. So after that, if we say, okay, there maybe were some concerning features that we found in either the history or the physical exam, we say, okay, how much testing do we want to do? Do we want to do a full workup? If they're younger, the answer might quite possibly be yes. Let's do a full workup. Let's get a baseline. If if they're older and they don't think it's necessary, we don't necessarily do all of it. But there are some things that we can do quite easily. So there are cognitive assessments that we can complete at the office, whether that visit or another one. There's the Montreal Cognitive Assessment. There are 3 different versions of that, so if you've had it once, we could do a different version. There's the it test more, it tests different types of working memory. So it tests more of the visual spatial, attention, concentration, uh, as well as some of the like memory recall types of memory as well. Whereas the mini mental state examination is a little more straightforward. But I do like to tell patients and their families that even if you do really poorly on those cognitive assessments, it doesn't necessarily mean that you need to go to a facility or something crazy like that. It doesn't tell me how well you're able to bathe yourself or help with chores and tasks and take care of yourself around the house. It's testing more to see where your strengths are and your weaknesses are. Depression screenings and anxiety tests are also very useful because anxiety and depression can mimic dementias. And then a sleepiness evaluation such as the Epworth, because once again, if you're sleep deprived, it can cause some memory concerns as well. Depending on where you are and how you did on the tests and questions that we do in the office, I might recommend formal neuropsychological testing. So neuropsychological testing tends to be about a day-long process where a trained neuropsychologist goes through and asks all kinds of questions to kind of tease out subtleties. So they have the ability to kind of determine whether you have like an early Alzheimer's, whether you have a like Lewy body dementia, or maybe even just a mild cognitive impairment. So they're able to tease out different things that take a lot of specialized training and extra tests. Then you can do imaging studies. MRI does give us probably the best picture that we can get of the brain, looking for atrophy or shrinkage of the brain or cerebral vascular changes such as small strokes. And those small strokes could add up to memory problems. CT is usually not as good of imaging study, but if you have like a pacemaker or any devices that are implanted that are not MRI compatible, a CT would be a good option. We usually get a lot of blood work done fasting, looking for vitamin deficiencies, protein issues, electrolyte imbalances, infectious organisms, and other things that we could possibly treat, and that could mimic memory issues. We usually get a baseline EEG to see kind of where, if the brain is slowing at all. Okay. Next. So planning ahead, taking steps to ease transitions. So as soon as you know that there are memory problems, that is the best time to start, or even if you think you might have memory problems, it is a good time to start building your safety net. In getting things in place just to kind of protect you as things go on. So one of the most important things is staying physically and mentally active. Make sure that you update your living will, designate a power of attorney for healthcare and financial decisions, complete estate planning to protect your assets. The government looks back a number of years, so if there's any concern that memory might be going, you want to make sure you're protecting things earlier enough that the government doesn't spend down all the money. Look for sources that are available in the community. The Alzheimer's Association, the Area Office on Aging, Senior Citizen Centers, Meals on Wheels, those types of things are available and usually affordable in the community. Also, see what home services are covered by your insurance and if they have any particular preferred providers. Things like PT, physical therapy, occupational therapy, speech therapy, social work, nursing assistants, nurses, housekeeping, those are all services that can be offered, and if your insurance covers them, that could be very beneficial to you moving forward. Look into different respite programs. Some places have respite day programs, and some have like temporary stays. So if you're going out of town for vacation, um, or you just need a break, the individual with memory problems could go there. Tour facilities and see what you like. I know right now it's kind of difficult to get in to see different facilities because everything's pretty much locked down. But hopefully when things open back up again, look into independent assisted living, skilled nursing, and memory care options at different facilities. I often recommend that if you're maybe in an independent living situation now, and may need more and more assistance as time progresses, look into facilities that have transitional care. So you don't necessarily want to have to keep moving to different facilities every time this happens, but if you're in different organizations may offer all of those services and help ease the family with those transitions. I tell people that my goal is always to keep my patients healthy, happy, safe, and at home. So we have to do what we need to do by utilizing all of these different services to keep them safe. That safety issue is probably the main factor determining whether or not they're able to stay at home. Okay. So considerations during the pandemic. It's been very difficult for a lot of families and individuals. So if individuals were in like an independent living situation, whether they're at home, whether they're in like a senior living apartment, uh, their lockdowns and the seniors are in that high risk category. And so they were told to lock down, don't go let anyone in, don't visit people. So it creates the social isolation. Maybe they had home health services that were interrupted or paused. Um, I know depression has been a big issue for a lot of our senior patients. And then a lot of patients, if they're stuck at home, they haven't been physically and mentally active. So instead of getting out and walking or doing exercise programs or whatever they were doing, a lot of them are more sedentary, which creates increased fall risk and other issues. So it's important that they maintain the physical activity during this too. Okay. So if they were in independent, assisted, skilled, or memory care types of units, there was a lot of restricted visitation and difficulty navigating technology. I know the longer this has gone on, a lot of facilities have maybe iPads that they are bringing into rooms and stuff to FaceTime. Um, it creates that isolation, and maybe if there are memory problems, the patient's unable to understand why the family and friends are not visiting. It's a change from routine without the group activities and dining. Um, I know I've seen some patients that maybe came in early and then they were completely quarantined for 2 weeks if they even left the facility. The social isolation, the physical isolation, worrying about the outbreaks in the facilities, and being in that at-risk population, that depression, physical activity, mental activity, and stimulation have all dropped off. So trying to figure out ways to stimulate all of these patients. Yeah. So here are some ways that I came up with that to help with cope during COVID. So turn off the television, limit how much news you watch. The news is very polarizing these days, and it can be very terrifying. And further create increased depression and anxiety. So trying to minimize that external television and news can be very beneficial. Um, Trying to do outside socially distanced visits if allowed, um, if the individual's at home, making sure you're maintaining as much distance as possible. Um, and visiting on a regular basis is fine, maintaining the distance, trying to wear masks, um, and washing hands frequently. So telephone and video conversations, you have to be able to balance the risk and benefits of isolation on the mental well-being and physical health. So, anxiety and depression are very serious issues, and so we have to make sure that um, we're addressing the needs of our patients as well. So, keep up care with their care providers. Um, Throughout all of this pandemic, I know my office transitioned pretty quickly into doing telemedicine types of visits. Um, and I know I had some visits where we would do conference calls. So I'd have, if, especially when it came to memory care patients. So I'd do a conference call. I'd have maybe the patient's children and the patient all on the call. And then we could all talk together and see how things were going. Um, and so making sure that you're keeping up with your care providers. Um, so can they do video appointments to establish care? So I know a lot of individuals who are in facilities right now are not able to go to appointments, or if they are, um, it's very limited. And so I know I have done a couple video new patient appointments for memory patients, just so that they don't have to leave their facility, and we can get a good history. We can get a pretty good idea of what's going on, and then eventually you'll come to the office and have a more thorough physical exam. But there are ways to elicit most of the information that we need over a video call. Okay? Okay, so caring for the caregiver, tips for self-care and more. I like to tell people that you can't pour from an empty cup. So as a caregiver, you have to keep filling your cup um, to be able to give to others. So some things, especially with burnout, so think about your barriers. Try stress reduction techniques, whether it's meditation, deep breathing, yoga or stretching, music. Prioritize your personal health. If you're sick, if you're ill, you can't care for others as well. So make sure that you're getting your normal preventative care, monitoring for unusual problems, making sure you're getting exercise. Um, Make sure you're eating well and sleeping well. The average adult needs 7 to 9 hours of uninterrupted sleep, getting up at about the same time, turning off electronics about an hour before bedtime. Easier said than done, I know. So don't go to bed with the TV on. Check on your emotional support and well-being, whether it's journaling, doing counseling, um, doing whatever you need to do to be able to take care of yourself. Take time off, even if it's just for a short time, whether it's sitting outside of your house for 5 minutes, 10 minutes. If you're able to exercise, go get dinner, even grocery shopping, whatever it takes to just get away for a little while. Join a support group and stay connected. I know the Alzheimer's Association has several different support groups. And then set goals. It can be very small and simple, but try to make sure that they're measurable so that you can, whether it's if you have a list, you can check them off the list just so you feel like you're accomplishing something. And it can be little things. It can be cleaning something, whatever it needs to be um, to make it be better. Okay. Okay, the VA has a couple of different really nice resources that are available for caregivers. So there's a caregiver self-care activity book, and there's a self-care assessment and daily attention diaries. So those are resources that you can find online, um, or you can which you can print off and use as needed. I thought they were very well done and can be very beneficial to make sure that you're taking care of yourself as well. Okay, so I found these top 10 high impact self-care ideas that take 10 minutes or less. So when we talked about getting away for even those 10 minutes, you can maybe make yourself a warm drink and read a chapter of a book. Listen to some of your favorite music. Do a brain dump or journal. Try emotional freedom technique. Go outside. Moisturize your body. Do something creative. Use scent to change your mood, whether it's like essential oils, perfume, whatever. Um, Go out and get yourself a coffee or tea or some other beverage of choice. Um, Throw out or organize something. Our brains like organization, so it's a very therapeutic technique. And then some extra things that you can do is you can meditate using an app or YouTube video. There's a lot of free resources and meditation types of things that are available. Make a smoothie, take a shower or bath, do stretching or yoga, or snuggle with someone. So when it comes to any disease process, the question is where are we going? And with that, there are research opportunities available. Um, I know the Alzheimer's Association can help match you with different clinical trials, um, but there's also clinicaltrials.gov. At clinicaltrials.gov, you can put in any disease process. It doesn't necessarily have to be dementia, but you can do any disease process, and you can see what are the ongoing studies um, in that subject area. Are there any studies that are recruiting or not yet recruiting? It tells the eligibility requirements, the study type, study results, study phase, funder type, study documents. Um, so when you're searching by disease process, currently there are 3,375 studies with the keyword dementia. 103 dementia studies are within 50 miles of Toledo, with 11 recruiting or not yet recruiting. And within 100 miles of Toledo, there are 205 dementia studies, with 28 recruiting or not yet recruiting. So you can look globally, you can look locally, and see if there's anything that matches your concerns, and see if you would qualify for those trials. Okay. Okay, and here are my references. And then that brings us to the question and answer session.
Great. Dr. Sarah, thank you so much. That was so informative. And I have some questions for you after we review the questions that were previously submitted. So I'll just go ahead and ask you these questions, and I'm sure that your answers will benefit all of us on the call.
I hope
So,
so.
yes, they will. They will, ma'am. Um, our first question comes in and says that my 71-year-old husband has been diagnosed with mild Alzheimer's. He has severe obstructive sleep apnea, possibly central sleep apnea. He uses a CPAP machine, but still has too many apnea events during the night. Could the diffuse brain atrophy and shrinkage, which was noted in his MRI, affect the I can't even say that word, it's late in the day. You know what word,
Autonomic.
autonomic signals to breathe while sleeping?
Yes, depending on what part of the brain um, has the atrophy, it definitely can affect the drive to breathe. I know there are, if he's able to tolerate the CPAP, there are special settings that they might need to go in and do the CPAP titration study again. And there's like SVT um, settings that are for central apnea as well. So it might that might be beneficial because, as I talked about earlier, untreated or undertreated sleep apnea can also contribute to memory loss. So you want to make sure that sleep apnea is treated if it's there.
We have a lot of our families that we work with, Dr. Sarah, that have sleep issues, not only with their person living with dementia, but also sometimes themselves as the caregiver getting a proper rest. And so, we heard about some different ways from you to, um, to help us decrease that stress, but also how important that rest is to our persons living with dementia.
Yes.
Um, Another question. My husband also has stage 4 chronic kidney disease with a current function rate of 23%. He doesn't need dialysis yet. How might the Alzheimer's disease and kidney disease impact one another? And might we expect the combination to cause a quicker decline in overall cognition and health?
Well, with kidney disease, that can cause some metabolic issues. So if electrolytes, if other elements are out of proportion, it can cause confusion and memory issues. So it's very important that if you're following your kidney diet and limiting fluids and doing the dietary changes as necessary to try to maintain as good a balance as you can. Um, I was gonna say, I know, especially with like if it gets to the point where dialysis is needed, there can be ups and downs depending on whether it's a dialysis day or a not a dialysis day when it comes to memory. So they can kind of play hand in hand with each other, and I don't know that there are any studies that conclusively say that yes, it is more rapid if you have both, but trying to maintain as good of control over everything that you can with electrolytes and kidney function would be most beneficial.
Great, thank you very much. Um, Just a reminder, folks, if you have questions for Dr. Sarah, go ahead and chat those in. If you go to the upper right-hand area of your screen, you'll see a little little box that says chat beside it. If you open that up, you can type your question in, and I am monitoring that chat feature. So, Dr. Sarah, we have a few more questions here.
Okay, good.
Um, my husband was diagnosed by a neuropsychologist with MCI 5 years ago. He has not been tested since then. Our family physician has prescribed the following medications: citalopram, metamine, and donazepam. Again, you know what I'm saying. It's late in the day. He
Yes.
does not recommend that my husband get tested for Alzheimer's disease. What are your thoughts?
I mean, it's really a personal decision. If you feel like you want to have a little further clarity of whether or not it has changed to a dementia type, um, that's perfectly reasonable. So he's on a good combination of medications, the citalopram, which treats the anxiety and depression, and then the donepezil and memantine. Those are the combination of medications to preserve memory. So those two medications work well to preserve as much memory as possible. So he is on all of the medications that I would probably recommend. And so if for your comfort, for what you want, if you have children, if you want to be able to plan ahead those ways, um, doing a repeat neuropsychological testing probably would be beneficial to your um, just just to be able to say, okay, yes, this is happening, this isn't happening, and just to be able to give you a little more clarity of what to expect down the line. Um, but if your insurance doesn't cover it, it can be expensive. So really, it's a personal decision. If you'd feel more comfortable knowing, it's definitely a reasonable request to do the neuropsychological testing again. If he hasn't had imaging or blood work or anything like that done, um, that would also be reasonable. And I mean, if you have questions, if you want further testing or your PCP doesn't want that, then ask if maybe you could have a referral to a neurologist um, to have that further evaluation completed.
Awesome. Thank you. Thank you, Dr. Sarah. Another question has come in. My 82-year-old wife has Parkinson's, disease dementia with tremors in her, disease dementia with tremors in her right arm and hand. She has some bowel incontinency issues where her adult diapers are a huge benefit. Is there anything else I can do in addition to clean her in the shower? Thankfully, I'm able to help her as I'm a few years younger and able to help. So a really good question from a caregiver in a tough situation. Dr. Sarah, what are your thoughts?
I mean, if she has bowel movement at about the same time, which hopefully, I mean, realistically, everyone should have a bowel movement every day. So if it's about the same time every day, maybe about a half hour before she would, you try toileting her. So instead of waiting for her to have a bowel movement, you try time toileting. So if she has other incontinence issues, maybe you're bringing her to the bathroom every 2 hours so that she hopefully goes on the toilet instead of in a brief.
Our listener typed in that not at the same time, very irregular. Okay.
Okay.
Um,
So if they're very irregular, make sure she's drinking plenty of fluids, eating foods with high fiber, and that might help with some of that regularity too.
Thank you. Next question. Mom's living in a transitional community and just moved from independent to enhanced living. How do you know when to move into assisted living?
So oftentimes the facilities are really great, especially when they have that independent enhanced living. They'll be able to tell. A lot of times they do case conferences on a regular basis to discuss the care, and so they should keep you up on to date on what's going on. And if they say, okay, she's reaching that point that with what we do, she's either not safe or we're not able to provide any more services to her. So to keep her where she is, usually they do a pretty good job of saying, I think she's kind of transitioning to to needing the assisted care rather than the enhanced living. So just keep that open line of dialogue between the facility and you.
Thank you. Okay. We had another question come in about the talking about the COVID, and we've seen this spike in cases. We just finally have a little bit of opening up for visitation. But with the spike of cases, Dr. Sarah, can you talk about we know that most of the folks living with Alzheimer's and dementia are living at home. What kind of risks are posed to our persons living with dementia at home, do you think, with this increase in COVID spike that we're seeing right now? And is there anything that the caregivers can do to help mitigate that risk?
I mean, if you're staying socially distant, washing your hands, masking, I mean, if someone has dementia, trying to get them to wear a mask could be confusing too. So, um, staying distanced as much as possible helps mitigate those response that the chance of getting the disease. But it's also trying to maintain that balance. Like if you feel socially isolated, depressed, and anxious from staying at home all the time, trying to get out and maybe go on walks around the neighborhood. Maybe you wait until most people are at work to try to get out so that there aren't as many people out and about on the sidewalks. Um, if you're using services, ask how they are screening their employees, making sure that they are screening their employees and the other people that they are providing care to. It's it is a concern. Anytime you have someone coming into the home, are they bringing anything with them? Are they wearing a mask when they're providing the services in the home? So just trying to do the best you can to minimize contact with lots of other people. If you are visiting with friends or family, try to do it outside as much as possible um, while maintaining distancing. So hopefully that's helpful.
Wonderful. Okay. Um, let's kind of switch gears a little bit and go back and talk a little bit about when folks come in to visit in the office with you for that initial diagnosis. You had talked a little bit earlier about getting as much information from the patient as possible. I actually am working with a family right now where the person who has the memory loss and some other symptoms, behavioral included, has been very resistant to coming in and seeing a neurologist. And her family obviously wants her to come in. Are there any suggestions or tips that you could share with me that I could share with this family to decrease her anxiety about the visit?
I mean, if the family is concerned, and that's a difficult one. um, you can't get people to do what they don't want to do most of the time. But it's not saying that they for sure have a problem. So it's seeing if there's anything that we can address. So it could be that maybe there's a couple labs that are off that we can fix and treat. So it's that Alzheimer's um, diagnosis is kind of that last resort. We're seeing if there's anything else we can treat first. So we want to see if there's a sleep disorder. We want to see if there's anxiety or depression. And it's if we don't find anything else that we say, okay, this is probably Alzheimer's or this is probably dementia. So it can just be beneficial to say, okay, like we want to evaluate this to see if there's anything we can do to help your memory improve, rather than just say, okay, we think you have memory problems, go see neurology. Because no one wants to be told that they have memory problems.
Very good. And then when those folks would come into the office, is there, I know you had said earlier, you're talking with the patient and having them describe to you what's happening to them. Is there a portion of your assessment that you're gathering information from the families on that initial time or not?
Yes, so what I do is I direct all my questions to the patient. So as soon as, so I ask, so are you repeating questions or conversations? And if the patient says, no, that's not what I do, and the family is over there shaking their head saying, they do that all the time. I say, okay, what's going on? Um, do you see this behavior happening? Does it happen frequently? So it's not, I'm just directing everything towards the patient, but I want to have what their insights are. If they say, well, I'm perfectly fine, I don't know why I'm here, and the family is telling me that there's huge issues, that throws up a big red flag. If they say, okay, I think I have maybe some mild memory problems, and what they're saying is in agreement with what their family's saying, then I might be a little less concerned because they have that insight to what's going on.
I think we all get challenged when sometimes the patient doesn't have as much insight, perhaps, as we as we wish they would. We had another question come. Thank you, Dr. Sarah. I can work with my family, so thank you. We had another question come in. Mom has severe hallucinations, which can mask a UTI. How can we minimize the hallucinations? Her treatment was or her medication was increased and seems to help.
So hallucinations can be tricky. So oftentimes it's finding the right medication and the right dose of the medication to kind of mask those. A lot of those are antipsychotic medications, which can carry risks of prolonged QT, which is a heart interval, which can lead to abnormal heart rhythm. So we do kind of have to be careful about how many of those medications we are prescribing and at what doses. Um, but as far as hallucinations, sometimes we think that maybe whether it's visual or auditory, that if there's lost sight or vision, that the brain's making up things to kind of fill the void. But other times, we're not really quite sure why they're having the hallucinations. And so it's usually medication management.
All right. I'm just, we still have a few more minutes left here with expertise of Dr. Sarah. So if you have any additional questions, please feel free to chat those into me. That would be great.
It looks
Um,
like Alvaline just asked, how do you take a car away from a person with dementia? That's another difficult question. So, usually I recommend doing like driver's evaluations if there's any question because people are usually very resistant, especially around here where there's not great public transportation, of having their freedoms taken away, by not being able to drive and go where they want. Um, so we usually get the driver's evaluation. If there's any question, if they flat out fail, we say, okay, you had problems with this, this, and this, you should not drive. Um, Unfortunately, as a provider, I can't just reach out to the driver's bureau or the state and say, okay, this patient failed their driver's evaluation and cannot drive, because that's a violation of HIPAA. If their family reaches out to the Ohio Department of Transportation and tells them that, okay, they failed that, that's fine. Or if you know people in the maybe local police department or sheriff's department that are willing to come out and help you out and say, okay, you no longer can drive. But oftentimes, if there's cars around, making sure that the keys are hidden or locked up, and just trying to minimize the chance of them driving.
yeah, that's a great question, Alvaline. Thank you for submitting that. I know that we get asked that question a lot. Families really struggle with the issue with driving.
Mm-hmm.
We had another question come in, Sarah. Is there a checklist of daily living skills you would recommend for the family to complete periodically at home to monitor changes over time and to have current information to share with you, the neurologist, when we come for follow-up visits?
I mean, I should come up with some sort of checklist for that because that would be fantastic. So,
Get on that. Yes. Yeah.
right. So, probably the most important things, are they eating? Are they able to shower? Are they fall risk? Um, are they toileting on their own? Do they need to be reminded? Those types of things. So, just are they able to complete those activities of daily living? Um, I know I usually ask, but a checklist would be a useful tool to have to say, okay, fill this out, maybe do this every month. If you notice that things are trending downwards, call and we can either get blood work or testing. I mean, or just call a check-in. That would probably be very beneficial to both the patient and the provider.
Yes, definitely. And I think we have some checklists through the Alzheimer's Association Dr. Sarah, that we could provide to that would help our families. So I just put my email in the chat for all of you. If anyone's interested in the checklist that we have, just shoot me an email and I will email you something back out to you for your support. We had another question come in. My husband has had OSA for 30 years and worn a CPAP machine. Now at night he takes it apart or pulls it off the night table or breaks things. Any hints for her, Dr. Sarah?
That is also difficult because confusion in dementia is real, and it they don't understand why they're wearing it anymore. And so whether maybe they need something to help them sleep a little bit more soundly at night. So maybe a medication at night might help. Maybe making sure that there's a good nighttime routine. So once again, minimizing stimulation, turning off electronics, kind of dimming those lights to kind of get you calmed down physically and mentally before bedtime. Maybe that'll help with better quality sleep at night so that he's not waking up and pulling off the mask through the night. If he's still having issues, you can either talk to the pulmonologist or whoever's managing the CPAP to see if they have any ideas, whether it's medication, maybe a change of settings, or just other relaxation techniques that might help with the sleeping better through the night.
Great, thank you so much. Well, Dr. Sarah, we are heading into the home stretch here, so I'm wondering if there's any last minute great wisdom that you want to share with our listeners here. And if we do have a couple minutes, if you have any last minute question you want to type in real quick, we'll try to get to that before 5:30. But do you have anything that you can share with us in closing that might be helpful for caregivers and so forth?
Whether you're a caregiver or anyone, just try to live a healthy lifestyle. So eating plenty of fresh fruits, vegetables, complex carbs, proteins. Make sure you're staying active physically and mentally. Things to help both your physical and mental well-being. So making sure that you're taking time for yourself and doing things that make you happy and leave you feeling fulfilled. So making sure that you're taking care of your complete self and just trying to be as healthy as you can.
Absolutely. You're absolutely right, Dr. Sarah. That's great advice for all of us, whether we're caregiving or not. So thank you so much. I think we have answered all of the questions that have come through in the chat and that were submitted ahead of time. So we'll just go ahead and give you back a few minutes in your day, everyone. But Dr. Hunter, we just thank you so much for taking time out of your very busy day and coming on here and talking with all of us. We really, really appreciate it. We work at the Alzheimer's Association. We work very carefully and a lot with Dr. Hunter at her practice there and trying to provide resources to her patients. So she's a great supporter of the Alzheimer's Association and the work that we do. So we greatly appreciate her coming aboard and sharing her wisdom with us. Again, Dr. Hunter is at the adult neurology practice at Levis Commons with Dr. Loomis, is where she works out of. So if you need to contact her or would like to go see her, that's where she is located. So thank you again, everyone, for being on the call today. Hopefully this has been helpful. Again, my email is there in the chat, pjmyers@alz.org. If there's any follow-up that you need from us, please reach out to me and I'll be happy to take care of that. So thank you, everyone. We'll go ahead and sign off. And it's again, Dr. Hunter.